16-year-old boy in the clinic with retinitis pigmentosa, and he wants to speak to somebody about research. And I went and spoke to him, and he said, he wanted to come work in the lab over the summer and help develop a treatment for his retinitis pigmentosa. So I said, sure. I knew he had a place at the shore. I didn't really think he was going to come to the lab. But sure enough, he came to the lab, and he identified the mutation that caused his disease and the gene that caused his disease, which turned out to be choroideremia. He gathered together his whole family, which had a great pedigree. He helped put together this pedigree, ended up diagnosing his cousin-to-be by amniocentesis and so forth, and it really became quite famous. He was on a television show called Connie Chung's Eye to Eye, which described his goals of try to help develop a treatment for choroideremia. He had seen his grandfather go blind, and he knew that he was going to be going blind at some point too. He was a early and big-time leader in the Choroideremia Research Foundation, the CRF, and recruited many, many additional supporters. This has had an international effect and really helped progress the clinical trials. He himself went to medical school and became an emergency room doctor, but was ineligible for some of the trials because of asymmetry of his disease. But he helped spur this whole program. In fact, he inspired people so much that some of them tried to bring mice from England to my lab for studies. Fortunately, they didn't get into trouble, and the mouse didn't escape in the plane. We ended up not being able to use these mice because they were infected with various contaminants that were not allowed in our facility. But this just goes to show you how dedicated these patients are. Instead, what we used were induced pluripotent stem cells, and Chris and his family activity was restored when we treated these cells, and that the protein localization was restored in the cells with these cells. And this led to a clinical trial which was led by Tomas Alleman and Rachel Huckfeld at Mass Eye and Ear, along with Jason Commander and Albert McGuire, who were the retinal surgeons, which showed a very high degree of safety through the 5 years that patients were followed. And this was really, and there were other contemporaneous gene therapy clinical trials that went further through phase 3, but this is really a big deal that we and others showed that it is safe to inject the central macula, the fovea in particular, for these kind of studies. Robert McLaren has proceeded with phase 3 clinical trials, and unfortunately it did not meet the endpoint, but there are ideas of how to move forward so that this gene therapy can benefit people. And this is what I hope will happen in the next few years. And for the final subject, I'd like to talk about LCA5. And early in 1988, there was a patient, 1998, there was a patient meeting that was held, the first meeting for LCA, that was held at the National Institutes of Health and University of Maryland. And that was initiated by a family that had a little boy shown in this picture who had LCA. Nobody knew what the genetic basis of his disease was. But this family put together all the people to help spur the development of the identification of the genes causing LCA. And this led to various conferences and the LCA5 consortium, which included Franz Kremers and people in his laboratory. The family helped support identification of this gene, which Annika Dan Hollander showed was LCA5, helped generate a mouse model, which was made at Jackson Labs by Patsy Nishina, and then helped fuel the proof of concept studies using this mouse in my lab. And this took place over many years without any funding or minimal funding during COVID, et cetera. But proof of concept was identified, and there were several companies that were formed that then dropped the disease because they thought it was too rare, went through 3 different companies before this could be brought to clinical trial. And however, it has been brought to clinical trial, and this disease is one of the first ciliopathies, I think, where we see promise of gene therapy-based intervention. It's ultra rare. There are an estimated 150 people in the United States. It affects retinal pigment epithelial cells and photoreceptors. It's devastating disease. It's diagnosed very early in childhood and is much more severe than RPE65 deficiency, for example, because it's an earlier onset. You can see from the images in this slide of the retina that the retina is really damaged. A lot of that is because the children poke their eyes and damage their corneas, but it's a very hazy view of the retina. But the LCA5 mouse, like the humans with LCA5, suffers a ciliopathy and a very rapid early onset retinal degeneration. In that slide, you can see that where the photoreceptors are colored blue, you can see that by day 30 after birth of the mouse, there are very few blue cells left in the retina. And there are very few outer segments that are shown in the bottom panel. But after subretinal delivery of an AAV containing the wild-type copy of the gene, there is a restoration or in a saving of these cells. They do not degenerate as quickly or as much. And you can see that by day 30, there's essentially a full complement of these photoreceptors, as well as outer segment discs, which are visible by electron microscopy. Shown here is Catherine Nuhesi, who did a lot of the work in this study. And further, if we look at their behavior and do a water maze test where the mouse is tasked to find an illuminated platform, the mouse finds it really quickly, there within seconds, whereas the untreated mouse cannot find this platform. And I won't make you watch this whole movie. It takes several minutes for it to be able to find this platform by randomly swimming. So we move forward with the clinical trial. We've finished the phase 1 studies, or the first dose of these phase 1 studies. This is 1 times 10 to the 10th AAVs per eye. There were 3 adult participants ranging from age 19 to 34 years old with very poor vision, hand motion, in the best vision sighted person was 2200, and with different mutations, 2 of them with homozygous mutations, 1 with compound heterozygote. And what we found was improvement in a variety of different outcome measures. Shown here is full field light sensitivity threshold testing, and you can see there is a trend in the treated eye only, not the control eye. The treated eyes are shown on the right-hand panels of these figures, of improved sensitivity using this test. And this is both for red and blue light. Furthermore, with microperimetry, we've shown that patients have much more sensitivity, and that the sensitivities in the eye are barely detectable at baseline in the treated eye, but after 30 days and then at 3 months, you can see great amount of sensitivity and much more focused improvement in the foveal area. And then finally, in terms of navigation, shown here, let me see if I can get this to play, a virtual reality test. You can see the untreated eye, the person walks around. The task here is to identify objects and touch them and make them disappear. And this is colorized for presentation purposes. And you can see using the untreated eye, the person cannot identify these objects. But using the treated eye, which is on the right-hand side, the person walks around and touches these objects and they disappear. Again, showing that there is real-life effects of this treatment. So to summarize, we are really excited about the potential for this therapy for this ultra-severe and ultra-rare form of Leber's congenital amaurosis. It's one of the first ciliopathies that we believe show great promise. And in summary, I'm very, very excited about the potential of treatments for multiple different forms of inherited retinal degenerations. As you've heard, it's been 34 years since that first gene was identified, and we all thought it would go much more quickly, but it has happened for some diseases, and we think that now we can speed things up and move things forward using the technology that is now available and the de-risking that has happened. There are great opportunities for progress and great possibilities of collaboration between not only academia and patients, but small biotech and big pharma. And I'd like to thank all of you, and particularly our subjects and the families that have been involved and the people who have made it possible to carry out these studies. Thanks so much, and I'm happy to answer any questions.
So thanks so much for a wonderful presentation, 3 wonderful stories. RP65, excuse me, choroideremia, I need a little glass of water, and LCA5. So thanks for the beautiful stories, Jean. We have time for 1 or 2 questions if there are questions in the audience. And I think we have a roving mic somewhere as well. So if there's if there's 1 or 2 questions. If not, in the meantime, Jean, I would like to ask you one question in terms of that reality test. How do you think that will go down with regulatory bodies? So the key thing in driving these therapies forward and actually getting them approvals will be that the regulators are happy with all of the outcome measures that we use. So FST, microperimetry, and also that reality test. I was wondering if you had any feedback from regulators as to how they feel about that.
Yes. So this is uncharted territory. There are very few devices that have been used to try to treat retinal degeneration. And so not only, so far we have dealt with the biologics organizations at the regulatory agencies in terms of gene therapy, but here we're talking about also using a device. The particular device we've been using has been, which is the Meta Quest 2, has been used in millions of people for entertainment purposes with very high safety record. And however, it hasn't been used to actually measure extent of vision in an eye disease. So it has to go through the device committees, at least for the FDA, and I don't know what the equivalent would be with the EMA or the other regulatory bodies. But so far they have declared it has non-significant risk. And so I'm optimistic that it will be approved as an outcome measure.
So I think that's very exciting because then there's a possibility of applying it to a lot of other IRDs as well for clinical trials, which is very exciting indeed. Well, if anybody has a burning question as well, Jean will be around afterwards for questions. Thank you so much. Thanks again to Jean. So I'd like to introduce our next speaker, and that's Professor Isabelle Audo from the Vision Institute in Paris. And we look forward to Isabelle's
congenital stationary night blindness of achromatopsia. Patients are born with visual impairment. It doesn't progress, but still it can lead to